Hi guys, welcome back to the channel. So last class we have started with infectious mononucleosis. We have seen that it is caused by Epstein-Barr virus, which is also a herpes virus. Okay, it mainly occurs in teenagers and young adults. The main symptoms or the complaint with patient come are sore throat, fever, malaise, headache, and cervical lymphadenopathy, which involves both anterior and posterior lymph node. Then there will be pharyngitis, causing pharynx to be red with a grey-yellow exudate. There will be tonsillar and gingival inflammation. And in some cases, particular hemorrhage on palatal mucosa can be appreciated. Patient mainly complains of fatigue, and it is the chronic mononucleosis is also suggested as chronic fatigue syndrome. Okay. Now it is mainly, and we have also seen that it is mainly transmitted via saliva through direct contact, and it was also known as kissing disease, and the incubation period for the virus was 5 to 15 days. Okay, let's start today's class. Now coming to diagnostic workup, we have seen in last class that two things we have to do, that is liver function test and complete blood count, which will show increased level of AST and ALT enzyme and neutropenia and absolute lymphocytosis. Now, some lymphocyte appears extremely large, mimicking monocytes, so termed as mononucleosis. But this is the misnomer, because it is actually a lymphocytes, not monocyte. It mimic monocyte because it appears big, or it become big. Okay, some lymphocytes will appear atypical, which is a hallmark of the disease. So 50% absolute lymphocytosis with 10% atypical lymphocyte is a diagnostic of infectious mononucleosis. Absolute lymphocytosis 50% and 10% atypical lymphocytes. Now coming to histopathology, lymphadenitis may show, the histopathology of infectious mononucleosis is not pathognomic. It mimics Hodgkin's and non-Hodgkin's lymphoma. So clinical correlation diagnostic workup is important in case of infectious mononucleosis, because histopath is not alone. It usually mimics lymphoma, Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay, lymphadenitis may show marked paracortical hyperplasia and follicular hyperplasia. So जो lymphadenitis होते हैं, it will show marked paracortical hyperplasia and follicular hyperplasia. Now proliferating immunoblasts can be appreciated, and within follicles numerous mitosis and focal area of necrosis with tingible body macrophages appreciated. Tingible body macrophages is that which have clear cytoplasm. Okay. Occasionally large hyperchromatic cells with multi-lobe nuclei and prominent nuclei resembling reed-stump bug cells may be appreciated. See, reed-stump bug cells are seen in mainly lymphoma. So this kind of cell can be appreciated in infectious mononucleosis also. Its histopath mimic lymphomas. Okay. Now coming to the treatment plan, no specific treatment is required. Antiviral drugs are ineffective against EBV. So Epstein-Barr virus is resistance to antiviral drug. Supportive care consisting of hydration, long-term rest, analgesic, antipyretics, and often penicillin or erythromycin to prevent or treat secondary streptococcal pharyngitis is of value. So mainly supportive care is needed along with analgesic, antibiotics, and antipyretics. Prognosis: in uncomplicated cases, the fever disappears within 10 days and lymphadenopathy in 6 weeks. Fatigue and malaise last for longer, around 3 to 4 months. But in complicated presentation, small percent of patients develop severe hemolytic anemia, hepatitis, myocarditis, or encephalitis. Overt splenomegaly to the point of splenic rupture is a life-threatening condition in this disease, and encephalitis. So both splenomegaly and encephalitis are rare, but it is a cause of death in infectious mononucleosis. That's all about infectious mononucleosis. We'll be starting next topic in the next class. Till then, like, share, subscribe and comment. Bye.